Welcome to Prime Time, a show for adults in the prime of life. I'm Susan Hoskins, the Executive Director of the Princeton Senior Resource Center. We're a nonprofit organization providing programs and services for older adults, their families, and caregivers in the greater Princeton area. We seek to educate people about current issues and connect you with the resources you need. The contact information for our organization will be on at the end of the show. Today we're talking about hospice and palliative care. My guests are Donna Gustafson and Patricia Anene. Yes, thank you. You're both nurses, I know, and yes. Donna, you're the Director of Clinical Services
Correct.
With Princeton Healthcare's hospice program. And Patricia, I understand that you've worked both in hospice and palliative care.
That's right.
I think probably the first question we should talk about is just what is palliative care and what is hospice? How are they similar? How are they different? So,
well,
Donna?
I'll start out and Pat can add to it, but palliative care is really comprehensive management of symptoms and promoting the quality of life. Not dissimilar to hospice, which is comprehensive, looking at a whole person, managing whatever problems and symptoms there are, and promoting quality of life. With palliative care, though, people are still seeking a curative treatment. So they may have a life, and do have a life-threatening, limiting disease, but their life expectancy could be a couple of years. But we're looking at the whole person, trying to manage physical problems, spiritual, emotional problems on the palliative care side of things.
I don't want to interrupt, but it seems to me that that's so important that somehow medicine has gotten away from looking at the whole person, and particularly with older adults are people who have those chronic, life-threatening kinds of things. There's more than one system, and yet the treatment system has been working in silos, so the heart doesn't talk to the lungs, doesn't talk to the... and how important to really look at the whole person and think about the comfort and quality of life. So people on palliative care can still be looking for a solution, a cure to the condition.
Yes, and we started having a palliative care program when we noticed the patients that were on our home IV, home infusion program were dealing with the same issues, many of them, that our hospice patients were, but they weren't ready to make the leap to hospice. And so we saw these patients, and all patients really should be getting holistic care, but we bring in other team members to address the whole person needs in both hospice and palliative care.
Now, so many people seem to think that hospice means death, that it's something that you only do in the last few hours or days of life. And it's my experience that by holding off to that point where there's no denying, nobody in the family doubts that this person is in the last days of life, you really miss out on a lot of the opportunities and services of hospice. So, Patricia, do you want to talk a little bit about hospice and how that differs from palliative?
Sure. Hospice is also for people with serious, life-threatening illnesses, but usually they have a terminal illness of some kind, and they have decided no more attempts at a cure for whatever reason. They don't want to go back to the hospital. They want to be home, and they want to be comfortable. They want to be surrounded by the people they love and get some more help, both for themselves and for the people they love. One thing that I really like that you said is that looking at the whole person, and in addition to providing a team approach, which includes both the doctor, the nurse, social worker, chaplain, and aide and volunteers. So there's a big team for hospice. In addition to that, we're trying to let the patient and the family drive the care. The care is not being dictated to them. They're choosing how they're going to handle what's going on with them.
That's so important, isn't it? Because at this point, many people feel that they have no control. Right. You may not have control over your bladder. You may not have control, but you feel like you don't have any control over anything that's going on, and to really have a voice in your treatment plan. And I think that my sense has also been that the team really does a nice job of explaining to people what their options are, because oftentimes people don't really know, well, what if I choose this? What if I choose that?
Right.
Will I be in pain if I stop this?
I think we do a lot more talking, a lot more teaching, and a lot more supporting, emotional support to people. And we try not to dictate to them. We let them decide, having been fully informed by us, what they can expect. But always thinking about their dignity and their quality of life. So important. I think people worry about that. What's going to happen if I need a catheter, if I can't get out of bed, if my pain is really bad. There are ways to approach that that really guarantee a person's dignity, and we make them feel secure that that's what we're going to do.
It's also my sense from working with caregivers that caregivers want to uphold their commitment. Mom, you wanted to be at home, we're going to keep you at home, but that the demands of care grow, and so you mentioned catheter, made me think of it, you know, that caregiver may not know what to do, or also very important, may not feel comfortable doing that, or the patient, the primary person, may not feel comfortable, you know, anything but my son is not touching me there.
Right.
And that's when the team again plays such an important role, that the nurse will come out and change the catheter.
Absolutely. Or help them the nurse will change the catheter, of course, but also help them figure out how the needs are going to be met. And that a lot of what that means is that we bring in support. Sometimes people want to hire extra support above and beyond what we provide, but helping them to figure out how to best manage things, making them part of the plan.
Now, is most palliative care and hospice care done in the home?
Definitely, definitely. In the home, and actually that's where most people want to be. And people do better. I'm sure you've talked about it in the past, and you hear it from the people that you work with as well. People want to be at home, they want to be in their own environment. So it is given 99% of the time in the home. On the hospice side of things, under the Medicare hospice benefit, there's 4 levels of care. And one level of care is given in a hospital setting where people have symptoms that just can't be managed at home. That's pretty unusual. The family works with us and that we can manage things in the home very well. So that's not used too much. There is a level of care called respite care with hospice where the family is just like so tired that we give the family a break for 5 days and place mom, dad, or spouse, whoever, in a nursing home. So they can just rest. Sometimes they've gone away, or they've had a family event they need to go to, right, Pat?
Right.
Haven't you seen
Like
that?
a wedding.
Yep. And third level of care is having a nurse in place around the clock to help prevent the hospitalization scenario. Again, we rarely use that because my team of nurses are really good at managing the symptoms and have quite a array of treatment options and orders from doctors that they can get. So again, most of it's given at home. Palliative care is under someone's normal insurance benefit, and that is for care in the home. So within hospital settings, there are often palliative care. There is palliative care and sometimes specific places for it in different medical centers, but on the home care side, it's always in the home.
Okay. I know that respite care is so important, and I'm thinking another one of the myths that I hear a lot about hospice, and that is that if you say, I'm going to be on hospice, I have less than 6 months to live. And
Right. Well, the Medicare guideline says that the doctor must certify that that's an expectation. However, we frequently have patients who continue to meet criteria beyond 6 months and they continue on hospice. We just have to be able to show that they meet the criteria that Medicare has set, but many, many times that does happen.
I knew someone like that who had COPD, and I think was on hospice or on and off hospice for 2 or 3 years. And that respite benefit was so important for her daughter who was living with her and taking care of her full time, because, you know, the years, the months go by and her level of need grew, but because she got really good care at home from the hospice team and from the daughter, she outlived the expectation. And I think it's important for people to know that that can be renewed. It doesn't mean that everybody packs up and leaves.
Right. So the doctor says, from this point today, to the best of my ability, I believe they have 6 months or less. So, you know, well, this can be a moving target. So, and when you were talking about the caregiver burnout and the burden on caregivers, that's one of the really great things about hospice. It's so holistic. It's really, the patient isn't just the patient. It's the whole family. It's care for the whole family. So we have a whole team of volunteers that come in. We have home health aides, and they really are a great support, as well as the nurses, social work, and chaplains, and addressing all of the needs. But I know our patients really enjoy the volunteers. Often they just, you know, and the spouse,
they come to read, they play games. I mean, you know, you can't just envision somebody lying in bed near comatose. I mean,
They can
people
bring in
want to live full lives, and
art therapy, music therapy, journaling, massage sometimes, bed yoga, I think they call it. Yeah. There's a whole array of things that they can bring in.
Maury has brought a lot of her drumming and her music
Oh,
to
great.
hospice work in past career, so I know that that's an important piece of it. But that really, again, gives the family a respite, and it's the one way that Medicare really provides such a holistic view, isn't it?
Yeah.
Sometimes people are really surprised to hear that when they need a home health aide, that the home health aide is not paid for by Medicare, just because you happen to need help getting showered or whatever, but you're not at that level of qualifying for hospice. And
Right. So that's what people often want, is that little extra assistance in the home, and that's not as covered benefit under general home care, but under hospice it's very much part of what we provide. And again, that's care for the patient, like volunteers focus on the patient, but it frees up the caregiver to get out of the house, go for a walk, sometimes take a nap, go shopping, go out for a cup of coffee with a friend, and just themselves get renewed. And anybody that's been in a caregiving position knows it's the dailiness and the ongoingness and the accumulation sometimes, often over the years of being a caregiver is very hard.
yeah, we've been dealing with that in my family with my husband's parents, and I recommended to my sister-in-law that she investigate hospice, because it was my sense that they would both at this point qualify under hospice. And I was really stunned when I heard back that the doctor wouldn't do it, that the doctor said, I believe that hospice is only for the last few days of life. And I thought, wait a minute.
No.
You know, the whole family is comfortable with this being the end of the journey in your mid to late 90s. And, you know, we see the signs. And if the doctor isn't there, then maybe there's not a good fit here. And since then, she has changed doctors, and they're both on hospice. And she's getting so much more support, which she needed.
Right, absolutely. It's a tremendous missed opportunity, I think, if people wait until they feel they're getting very close to the end. I've had patients who, on hospice, who are still getting out, they're still driving. This isn't the norm, but you don't have to be homebound to be on hospice. You can have still a really tremendous quality of life, but you know that a process is coming, that there is an illness occurring, and eventually the need will be there, and we can kind of transition. Sometimes people only want to have the nurse to start with. They don't need the aide to start with, or they don't feel they need the chaplain, who I think is very important, but that's my bias. But they'll transition. They'll go months with just needing the nurse, and then we'll bring the aide in as a person has that need, or then we'll bring the chaplain or the volunteer. So,
Well, I know also, it's one of the things that makes me sad when I hear that people have put it off, and then they say, well, we only had hospice for 2 days, and they really didn't do much. And I'm saying, well, that's because you waited until 2 days before, and I know from working with all of you that there are so many services that you can bring in if the family's interested, and that can support everybody and guide everybody through that journey. Many families have never been down this road before, and sometimes it can be a little scary or a little anxiety provoking, or just you have questions like, you know, my husband did this last night, is that normal? What does this mean? And to know that the nurse is going to come out the next day and we can talk about that. And you guys have time.
You
know,
that's
you're not on that 12-minute doctor visit.
That's right. We do spend time with our patients, and that's one of the gifts of hospice, I think, is that you really get to know your patients, you really get to know your families, you feel like you can really be there with them, that you can spend the time with them and help and support. And that you don't have to wait until the next day for the nurse to come out. We have an on-call nurse available 24 hours a day. That's another big advantage, I think. Something happens in the middle of the night, you just call, and we'll give you guidance.
And back to this holistic approach, Donna, you can talk about this more, but it's my understanding that you also have team meetings so that the whole team gets together and talks about it. And I know that sometimes when people are in the hospital or something, they just wish that the cardiologist would talk to the neurologist, and oftentimes they do, but the idea of the whole team being able to say, well, this is what I saw, this is...
Exactly. They meet at least every 2 weeks, and sometimes more often on a case when things come up in between, but, well, I'm working on this, or this daughter told me this, but someone says, well, I talked to the daughter in California, and she thinks this, and trying to bring all the pieces together to make a care plan, as we call it in our professional terms, but a plan that cares for the patient and cares for the whole family. So, yes, it's holistic in the sense, too, that the whole team gets together and talks about it. And it's goal setting also. You know, I was kind of something you said earlier kind of triggered back to it. It's both palliative care and hospice is trying to help people figure out, like, what do they need to do to accomplish their goals and the whole thing. Like, a lot of people haven't been through death before or know what to plan for and what to expect and how they want it to go and to prepare. You're right, it's very difficult to do a lot of work in 2 days' time. You can't prepare people very well unless they have been talking about it ahead of time. So that's one of the nice things about palliative care too, because you try to define people's goals, try to get them to talk about, you know, how much you want to pursue a certain treatment or an activity, or what do you hope and dream for that you can accomplish, and well, how could we
What's
make
your
that
legacy?
happen? Yes. So,
and I think sometimes people just don't know what the options are, and so having other heads in there. So when should a family begin to think about hospice or palliative care as an option to begin to talk with their doctor about? Because it may not be the doctor that initiates the conversation. So what kinds of things might be?
I think the first thing the most obvious start point would be when you get that diagnosis of a terminal illness. And then I think you always want to know what all your options are and have the doctor explain that to you, and what would it mean to pursue this kind of treatment, and is that something I want to do? And of course, it's always the individual's decision. At my age, how will I tolerate given therapy like chemo or radiation? And then if you've decided that for whatever reasons you don't want to pursue an aggressive kind of cure path, then hospice would be a good choice. We could, as I said, we have patients who are actually still feeling quite well. Not all of them. Some people are sicker, but we do have people come on early in a disease process. And I had a patient with prostate cancer, and he kept saying to me, I don't understand why I'm feeling so well. I said, well, take advantage of it. He went to Ocean City with his second daughter. He was living with the first daughter. You know, he went out and got his favorite crab cakes or whatever. He had the time to do that. And eventually he did need more services, and we got them in there, and his time came. But he had a great quality of life for a long, long time. So, but I think definitely when you get the terminal diagnosis, you want to think about what your goals are, as Donna said. Are you really going to go for a cure, and what is that going to mean to you? And if you decide for your own reasons that you're not going to, then I think hospice might be a good choice.
Another myth that comes to mind is that I think sometimes people feel once they've chosen hospice, they can't change their mind. And you can never have treatment again. And yet I know that maybe you can address this, that people flip back and forth. Let's say you're on hospice, but your big toe gets infected. You can treat the big toe, or, right?
Yeah, right. And people also sometimes waver on that choice and just say, oh, I just read in the paper about this new treatment for my disease. I really want to pursue that. And, you know, that's their choice. Just like making a living will may change from when you're a younger, middle-aged person to an elderly person, and life situations vary, and you can change your mind.
I always tell people the first day of care that you're signing on with us now, but this is not irrevocable. If you change your mind, you're just going to sign off, and you're going to go back to your regular insurance benefit. And for whatever reason.
If you wanted to go into the hospital, get treated for something, you could do that, and then you'd come back on again when you come home again.
Could I add something back to how do you know? I think we have a lot of patients, more than 50% of our patients do not have a cancer diagnosis. They have end-stage cardiac, pulmonary diseases, other medical problems, and they've lived with that a long time. So it's not like you got a diagnosis that you have, you know, cancer and you're going to die in some, you know, a year, whatever. So there could be some triggers on that. Along that line, frequent rehospitalizations, an overall decline in your ability to do daily functioning, walking, bathing, you know, just dressing, a general deterioration in your overall health. But often a trigger is to see a pattern of repeated hospitalizations, multiple doctor visits for multiple systems. As you said at the beginning, sometimes doctors don't look at the patient holistic because they've been trained to look at lungs, look at kidneys, look at the heart. And so when you're going to all these different doctors and they're all kind of breaking down.
And then the medications start conflicting.
Oh my goodness, yeah. So that can be a trigger with multiple health issues and the frequent needing to see the doctor and frequent hospitalizations.
That's one of the times that I often recommend that a family ask for a palliative care consult, because I feel like there are all these separate pieces and nobody's seeing the whole picture, and the family's confused, the patient's confused about what choices to make. And so to have somebody that sort of takes a step back and looks at the whole picture.
Yes. A gerontologist that we work with, Dr. David Barilli, you know, often suggests that people really do see a geriatric doctor because they are trained to look at all the pieces and put it together as a whole and can give a picture, a more realistic picture to a patient about their overall health, their overall prognosis, overall where they're going, and that's very helpful. We all need that big picture. We need all the pieces put together. No matter what we're dealing with in our life, we often can kind of fragment it and, you know, let's look at the whole picture here.
Yeah.
So,
He really helped somebody that had come to me and said, her initial question to me was, how do I get into an assisted living? Because I don't think I can take care of myself fully anymore. She had a terminal cancer diagnosis. And, you know, as we went on and talked, I said, you know, let's see if we can get you a consult to do this. And we got her 6 or 8 months of continuing to live in her home because we brought services in, and she just loved being able to maintain that independence. It turned out that she wasn't able to afford assisted living,
Right.
so her option then was nursing home or going to live with her daughter. She didn't want to burden the daughter. So we were able to extend that period of independence for 6 or 8 months, and then the whole family had planned together how to make it through those last couple of months, and she was so grateful.
I'm sure. Yeah, that's a big goal of ours, is to allow people to maintain their independence as long as possible. That's
Yeah.
always in our goals and orders, and we work very hard to do that.
Yeah. And pain management is a pretty high goal too, isn't it, of being comfortable. You don't have to be in pain.
Right. That's big in both hospice and palliative
Yeah.
care. And not everybody will have pain, but many of our patients do. So we have many, many ways. We work with a special pharmacy managing pain. We have a pharmacist we can call and consult with. And the doctor, of course, is the one who originates the orders, but we work as a team. In addition to pain, we're frequently controlling other symptoms like anxiety. Sometimes there's something called breathlessness or shortness of breath, difficulty breathing, fatigue, all those bowel issues that can crop up, depression. So we work a lot on pain and symptom management.
Right.
It's a big part of
And
what
there
we
does
do.
need to be a family member or a person who's a part of the team. Is that right?
we have people who
Right.
live alone,
Okay.
but we need to make a plan again. It's part
Right.
of planning, like when you can't take your own medications, when you're not safe alone, what's the plan?
Okay.
So,
Any last thoughts?
we're just really
Anything else
grateful that you allowed us to
Well,
talk
thank
about
you.
this, because we think the service is underutilized and people aren't aware of what's available for them
Yeah.
and need to start
Well,
talking
thank
about
you
it.
so much to both of you for joining me today. I think this is such an important topic, and the information about the Princeton home care and hospice your contact information will be up at the end. So thank you so much for joining me.
Thank you,
Thank
Susan.
you.